Before we dive in, I want to give huge shout outs to community partners Epilepsy Foundation of America, the Danny Did Foundation, and Epilepsy Alliance America. And big thanks to sponsors Neurelis and SK Life Science. Thank you for believing in this podcast and to help keep it going. All right, y'all, pull up a seat. This is going to be good. Hey guys, welcome to this very special episode of What the F. I am at the International Epilepsy Congress in Lisbon, Portugal right now. Have the honor of speaking on 2 panels here, but there's so much more than panels. There's posters about research. There's all these resources here. You can just sit down and hang out and talk to an epileptologist from around the world. So I'm going to take you in and show you what it's like.
So my name's Hester Garrett. I work as a neurology clinical fellow in Newcastle in the UK. But I'm a junior doctor, so I'm just learning about epilepsy at the moment, getting more experience, doing different projects, and yeah.
What do you feel like has surprised you the most about epilepsy?
Gosh, there's so much. I feel like I just learn so much about epilepsy every single week, but probably just how diverse it is and how people can have such different symptoms from it. So I suppose everyone classically just thinks of like a convulsive seizure as being like the only seizure type. But there are so many more different symptoms that you can get with epilepsy, and that's just the seizures alone. And on top of that, I feel like was it your question the most surprising, did you say?
Yes.
Yeah. I suppose everything else that comes along with it. So the uncertainty about seizures and how it affects people's lives in that way. And the intellectual disabilities and cognitive effects that people have, and mental health things. I mean, it just comes with a full package beyond the seizures.
It sure does.
Yeah.
And it is like very sneaky because I feel like when I was diagnosed, like I didn't know all of those things that came in the package either.
Yeah. And I think the most interesting line that I ever heard from someone living with epilepsy was, and I can't remember his name, but he was the American filmmaker guy who's made a film that's being shown.
Miles Levine.
Yeah, when he said that the only time that he's not living with epilepsy is when he's having the seizure, because it just reflects like the uncertainty around having it and not knowing when you could have one. And yeah,
and you don't remember it.
Yeah.
And so it's like the only time of epilepsy that you aren't actually a part of, which is so weird.
Yeah,
Totally.
really interesting and quite emotional thing to hear as well.
Yeah, absolutely. So is this your first time at IEC?
Yes, it's the first time. I mean, I've been to the ILAE conference in the UK, but I've never been to this conference, and I've never been to such a big conference before. But I think it also shows what an interesting area of neurology and medicine epilepsy is. And as a junior doctor, I feel like it's quite inspiring, quite motivating, and it should hopefully get more people interested in it and pick up projects and become good neurologists.
Well, as long as we've got people like you, I think that's definitely where this is headed. I really appreciate your work. I appreciate you being here. I appreciate your interest in making the world for people with epilepsy better. And thanks for sharing your time with me. Yeah, you as well. You too.
I'm an adult neurologist with a particular interest in childhood onset epilepsies, particularly the developmental epileptic encephalopathies, which is often the combination of a neurodevelopmental disorder with severe epilepsy, often involving multiple seizure types that can often be resistant to treatments.
David, you just said 14 words that I don't understand.
Correct, so let's go through them.
So talk to me like I'm 5.
Okay.
Like I am a child. Okay. So you said developmental epilepsy. What is I know this is just, I'm showing my ignorance. I have no shame about it. So
That's
what
fine.
does this
That's
mean?
Important. So, epilepsy is not one disease. It's a group of disorders which can be very, very different, which share in common an increased risk of having a seizure. Any person can have a seizure. They don't necessarily have epilepsy just because they've had a seizure. But some people have an increased risk of having seizures without any clear cause. The different types of epilepsy can come on at different points in life. The developmental epilepsies, which are the ones I'm more interested in, will often come on in childhood, sometimes very early childhood, sometimes later on, even in people's teens, even early stages of adulthood. But we conceptualize them as epilepsies which have emerged because of the way somebody's brain has formed and matured as they've grown up.
Got it. Okay, but now I am still more confused because I miss it? You said you were an adult epileptologist, but you are interested in childhood epilepsy. Can you explain that to me?
So children grow up. And one of the happy stories of working in this field is my colleagues who are pediatricians who look after children have managed to make huge changes to the way that people with severe epilepsies can live as young children now. More children with severe epilepsy are living into adulthood, have got greater levels of independence, greater levels of function, and when they become adults, they need an adult doctor. So I'm somebody who's got a particular interest in taking over the care of these people as they transition from being a child to adults. And it's a slightly different mindset to the way that many adult neurologists have thought in the past. So a lot of adult doctors who specialise in epilepsy will tend to see people whose epilepsy developed when they were already an adult. So they didn't have it as a child. And those epilepsies, bearing in mind that these are all different conditions, will often have different symptoms, affect their lives in a different way, require different treatments. And so there's a slightly different set of skills for the doctor looking after them should have. And
I just appreciate so much that you want to dive into that history, because I wasn't diagnosed as a child, I was diagnosed as an adult, but I've talked to so many people who went from that pediatric to adult epileptologist, and it felt like just starting over. And it is to a certain extent, but the fact that you are concerned with the developmental part, you are concerned with what happened before, that's just very inspiring, and I really love hearing that.
So I think most neurologists, when they meet a patient for the first time, will want to go back to the beginning of the story, because that's what gives us context to what the patient's living through now. And without that context, you miss out on all sorts of opportunities to learn about what might help. Some of the epilepsies I'm involved with are genetic conditions where there's something in somebody's blueprint they've inherited, which is nothing that we can fault them for. We can't fault their parents for. It's a bad luck thing. And it just means their brain has developed in a slightly different way. So like somebody might have autism, or somebody might have ADHD, someone might have a propensity to depression or anxiety. Epilepsy is one of those
all of the above.
All of the above. The things that actually little bits of this and that are part of what make up our personalities. But for some people, the way their brains developed, it just gets to the point that it starts causing problems. And epilepsy's an example of this. We're learning more about the genetics of epilepsy. And as we understand more about that, we understand more about why does one person have epilepsy and another person doesn't. And then amongst the people who have different epilepsies, why might one person's epilepsy affect them in certain ways that the next person we see in our clinic room might have a very different lived experience of epilepsy. So we're gradually getting further and further into understanding the basis of the causes of epilepsy. That can guide our treatment. It can guide the advice we give people. And I think it's a really exciting time to be working in this field.
Okay, so that's how I feel, even though I'm not working in the field. But just being here at this conference and hearing all of the things, all of the developments, the research, everything that's happening, I've felt that way in the last few days. Has there been a talk or a presentation or a poster or research, anything that's like really sparked your interest so far? I know we're only, halfway through the conference.
So from my point of view so far, the exciting sessions have been where I've shared a room with pediatric colleagues, so with doctors who see children but not adults typically, and where we've been able to bounce ideas off each other. Because we learn a lot from our pediatric colleagues. Obviously, if a colleague of mine has looked after a patient from the age of a few months old up to the age of 18 or 20, and then I've taken over the care of that patient, it makes sense for me to listen. And similarly, in these big conferences, where we can share a room together, we can exchange ideas and thoughts, and with professionals who have a slightly different perspective to our own. Similarly, I've met psychiatrists here who, again, many psychiatrists look after people with epilepsy. They have a different perspective. It's complementary to the one that we have as neurologists. And just getting the opportunity to meet people, share what we've learned from our own perspectives, what we've observed, gives you hope that we'll eventually find more integrated care, better solutions to the challenges that people living with epilepsy face every day. And with each passing year, life living with epilepsy will hopefully be a bit better.
Oh my God, I love that. Thank you. I appreciate that so much as someone living with epilepsy. So Would you mind explaining to me what your poster presentation is about, what your findings are? And I love how it's just talking about like the interaction between, it's just more than the brain. Epilepsy is affects more than the brain. Yeah.
Yeah, epilepsy is not only about seizures. So we have this study. We studied the prevalence and possible association of brain-gut axis disorders in children in a Colombian hospital. We already know that DGBI have a prevalence around 23% in the general population.
And could you explain DGBI?
Yeah, we already know because this is common for other neurological disorders like autism or schizophrenia that they have a higher prevalence of gastrointestinal diseases. Because there is a connection between our brain and our gut by a big nerve called the vagus nerve. So we found in this children that there is around 36% of gut brain disorders, so it was much higher than in the general population. And we found that around 10% are suffering of more than one gastrointestinal disorder, which is pretty common in the general population.
Okay, wow.
We already found that there is maybe a relationship between epilepsy and cerebral palsy to facilitate more gastrointestinal disorders. And we found that the children with a history of epilepsy surgery have a higher risk of functional constipation.
So now that, first of all, thank you so much for this work. I appreciate it so much. But once we have this information, do we know how to apply it to treatment yet or not yet?
I think that it is useful because in all the patients with epilepsy, the health personnel have to search for gastrointestinal disease, not wait to the symptoms appear. We have to search actively for this comorbidity.
Okay. So you be proactive with it rather than
proactive and ask about it.
Okay.
Because it is part of the disease.
Yeah.
It's not only about seizures.
Yeah.
That is the point of the iceberg.
Yeah. Yeah. Wow. Thank you so much. This is absolutely amazing. I really appreciate your work. As someone living with epilepsy, this is something I've never thought about before, and I feel like it just opened my mind. So thank you so much.
Thanks a lot.
Really appreciate you.
So my name is Mary Bita. By training or profession, I am an implementation scientist.
Okay, so that's super smart. Now you're going to talk to me like I'm 5, okay?
5. So that essentially means I take research findings and then I translate them to policy and practice. So for example, as someone discovers a new drug, my research work entails how does that drug get to the patient? What are the health system barriers? What are the costs, the challenges, etc. But in this conference today, I am presenting a poster on the ethics of artificial intelligence, on neurotechnology, or very simply put, we know AI is here, it's been here for a while. It's now being used in the medical field to develop and deploy neurotechnology like EEGs, etc. But what are the ethics around it? How accessible is it? How equitable is it? And people like from low resource settings like Africa who are not involved in the development of this AI, do they get access to this kind of technology? That's what I'm presenting in my poster today.
Wow, that's amazing. Okay, so again, pretend I'm 5. So it's like when you dive into the ethics of it, like what are they? Because it's something that I'm still wrapping my head around and I cannot figure out. So what did you find? Or what does your poster talk about? Or what does your presentation talk about?
I asked people, what do they think the ethical challenges will be with all this evolution of AI, etc. And maybe I'll tell a little story to just elaborate what I mean. Yeah. For example, we know that with EEG machines, there have been challenges, for example, with their sensitivity, depending on how melanated your skin is. So, for example, the darker you are, some EEG machines are less sensitive to people who have darker skin. Just very simple things like those. Other things are like the methods that we're using to train the artificial intelligence machines to read EEGs and interpret them are mostly being trained by people from the Western world. And then these models are being deployed in low resource settings like Africa or other areas to participants who are not involved in training these data sets, which means the data sets are likely to have some misinterpretations. Although we say the brain is the same, but it is important to have inclusivity. So I asked people, what do you think will some of the challenges be when we get these models and this equipment that has been developed using data from these Western worlds and just deployed them directly to our settings? And some of my findings were big things people are concerned about is issues like equity. Will we, as usual, from Africa be the last to get it? Will we afford it? What happens when we say our data is being stored or saved in a cloud, which is the term that is usually used? What is the cloud? How safe and secure is my data? And think about epilepsy. It is sensitive medical data that has many social issues like stigma. Do I want a random person having a scan of my brain from a random part of the world? And in future, we know that this data might be accessible. So you can go to the internet, extract information about the structure of my brain, and then know, for example, that Mary has epilepsy and you stigmatize me because my data was stored in the cloud 5-10 years ago. So these are some of the questions I'm trying to address to make sure that as we deploy this neurotechnology and use AI, it is safe, there's privacy, it is equitable and accessible to everyone, regardless of age, race, socioeconomic status.
Wow, that's incredible. First of all, thank you so much for your work. And I just appreciate the eye-openingness of it. And then also just trying to protect patients is really what it comes down to. That's amazing. Well, I can't wait to stop by your poster. Thank you so much for chatting with me, Mary. I really appreciate it. And congratulations.
Thank you. I am in Pavilion 4. I'm just at the entrance. Do come by.
And we won't miss you. We'll be right there. Thank you so much.
Dr. Nicolas Schnitzler from Buenos Aires, Argentina.
Well, it's so nice to meet you. Could you tell us about your poster here?
Okay, my poster is about a disease that it's called SYNGAP1 mutation. It's a mutation that encodes a protein that is responsible for a correct neuronal functioning. So when you have this mutation, you have several problems like epilepsy, global developmental delay, ataxia, different problems that are originally for this mutation. So it's very important to diagnose this disease because nowadays you have some treatment options that are ongoing study. So we are really very in an important position to make a diagnosis and work together with the families. I mean that it's not only the knowledge, it's also being empathetic with what's happening and trying to explain in a maybe clear way and also mentioning the positive situations. It's very common that doctors maybe keep on talking about the bad situations or the negative part, but there's also a positive part. And these patients are all of them being followed in Argentina, and still why? Because most of them start in the same way with a global developmental delay, and then epilepsy comes, and most of them have intellectual disability. So maybe nowadays the treatment is the same for all of them, but sooner is going to have a specific treatment. So precision medicine, it's coming.
Thank you. I mean, that's amazing work. And I just really appreciate how you approach it. When you say that, there's empathy involved, and there's also let's talk about the bad stuff, but let's talk about the good stuff. And yesterday, when you and I just happened to be sitting next to each other, you had mentioned something so beautiful about the development of how the epilepsy space, how you've seen it develop. And so I'm going to ask you to remember to quote yourself.
I don't remember exactly that. No, what I think is something is really complete if we feel the same, and we make our best effort for the patients, but walk with patients. And walk, I mean really walking, feeling.
I think you said arm in arm yesterday. Is that what it was? Yes.
Yes.
Oh, it's
Walking side by side, right?
so beautiful.
It's possible. I mean, that's the way I try to work. For me, it's a work, but it's more than a work. A job, sorry. It's like how I think that I must live. I must help in my way. I mean, I must do my part, and I must learn a lot, but I must feel. So I think that feeling it's really important part. Recharging batteries, of course, because to give you must have something to give. But it's possible. Doctors are just part of a chain. Maybe the strong part of a chain, but the chain is complete with every part working together and doing our best.
Thank you so much. I appreciate you so much. Thank you for your work and for your view and how you go about your work. I really appreciate you.
Okay, thank you so much.
Yeah.
Hi, I'm Ivana. I'm the president of Fundación Epilepsy from Argentina.
Hi, Ivana. It is so nice to meet you.
Thank you.
Would you mind telling me about your nonprofit?
Yeah, so we are actually a community, one of the largest in Latin America. We have around 30,000 followers, and what we do is we educate people around epilepsy. We share videos around epilepsy. We have an online campus. We also have events, not like this one, but for people to, educate about epilepsy and talk about it in an easy way, in a fun way, and to share the journey around epilepsy.
Totally, and so I have a podcast that kind of does the same thing, talking about it in like a fun way, adding humor to it, just making it not as scary, even though it is scary.
Yeah.
What got you into this space? Why did you start this nonprofit?
Well, I have epilepsy too. Yeah.
Yeah. It's the only place you can high five about both having epilepsy.
Yes, exactly. It's like, there.
Yeah.
So yeah, I have epilepsy, and I didn't find a place to talk about it in Spanish. I was doing a master's in New York, and I found the Epilepsy Foundation, but I couldn't find a place in Spanish to talk about epilepsy in an easy and fun way. So I sort of decided to create my own, and yeah, so that's how it all started.
That's amazing. I love that. That's wonderful. And it's just, I mean, it's doing so well and has so many people involved in it. Like, how does that feel? Like, how long has it been around, and how does it feel for it to have come this far?
It all started as a Facebook group, and I have a huge family, so now I can't say that 30,000 people is my family, but kind of, yeah, kind of. I have a huge family, so kind of, and so yeah. But it all started as a Facebook group, and it grew from that. People really feel supported. What happened was I was doing with the Epilepsy Foundation, I was doing a tour, and I remember meeting a girl who was segregated from her family because she had epilepsy. So I thought, okay, I am so lucky because I have a family who loves me so much. I have so many friends. So I want to create the biggest, community online who helps each other, who loves each other, so that no one feels segregated and has a support group. And we kind of are like that. We all sort of love each other, in a crazy way.
I'm tearing up because this is absolutely amazing. And I just really appreciate you doing this work. Thank you so much. Because I just think about all the people that you have helped, just by creating this, and then they connect to each other, and you created a family of 30,000 people.
It's kind of, yeah, well.
It's okay. It's a great thing.
Yeah, well, it's kind of, I don't know.
Oh my gosh. Well, where can people who are tuning in, where can they find information about your nonprofit?
It's online. We are in most platforms, but if you Google Espacio Epilepsia, you will find us everywhere in every Yeah, we have, and maybe we can do an interview together.
I would
someday.
love that. I would absolutely love
We
that.
can talk
Okay,
about all the shady
it's going to happen.
Yeah,
Yes.
we can talk about all the shady things regarding epilepsy someday. Yeah.
I know that might need to be like a 3-part episode to talk about all the shitty things.
Yeah, definitely. Probably, yeah.
100%. I would be honored to have you.
Yeah,
For sure. Yeah.
definitely.
It's so nice to meet you.
Yeah.
Thank you so much for all the work you do. I appreciate you so much. Can I give you a hug?
Yes.
I'm having you. Thank you. I'm so excited that I caught you guys outside chatting. And so, Moksh, could you first explain who you are, what you do, why you're here, and all your hopes and dreams? In 30 seconds, go.
All right. I'm here because I'm an epileptologist and I'm working in Melbourne running a clinic called Epilepsy Network Australia, which provides telehealth services all over Australia and particularly improving access for people who identify as Aboriginal, because that was one of the things that I had never, I was not seeing any patients even though I had thousands and thousands of patients. 4% of Australians are Aboriginal and they have twice the incidence of epilepsy. So 8% of my patients should be Indigenous, but they're not. So now they are. In my clinic, about 4%, still not reaching the mark that we should, but better than nothing.
Wow, that's incredible. Thank you so much for that work, because
Thank
it's
you.
super, super important. How's the conference going for you so far?
Fantastic.
Yeah?
Loving it. Particularly the first session today was absolutely amazing.
First session meaning Tori's session?
No, first presidential. When the presidential symposium.
Yeah, the president. Yes, sorry. Oops, that's what I meant too. Yes.
They've all been great.
Yeah, totally.
Always the best part is not the sessions, but meeting people like Tori, like
I
you.
agree. Oh, and Tori, it's so good to see you, like, in human form. Like,
Oh my gosh.
I know, like, you're real.
Yes.
So yeah, if you could tell everyone, everyone knows who you are and what you do, but
I'm just this random from London in the UK, Tori Robinson. I have an epilepsy and I have a podcast. Epilepsy Sparks Insights, where I interview clinicians and researchers to try and bridge that gap between the aforementioned and the rest of us, because it's exciting research, but also expectations need to be managed. And it's good to kind of encourage PPI as well, public patient involvement. And I get bored of people just in the UK, you see, so that's why it's great to meet people from everywhere and have them as guests as well.
that's amazing.
You think I'm joking and I'm not.
No, I know. That's why I love you. Yes, and you've been a guest on my podcast as well. Everyone should go check that episode out right now because it was hilarious.
With the best name ever, What the F. I promote you globally, by the way.
Oh, thank you.
You should check out What the F. They go, what's that? Oh, yeah.
And you've done like 14 panels or something today.
So I did one yesterday, one today. I'll talk tomorrow morning, if I'm recalling this correctly, is about the things that are never brought up in appointments. But are equally important as what people, or often equally as important, not always, as things that you might think, bring up seizures, but we're talking about quality of life. So things like sex or shagging, going for a poo, constipation, but also things like suicide. Incredibly important. It's much higher rates in people with an epilepsy and other things to do with mental health. And I think that we've got 5 things beginning with S, but stigma, and stigma, and how does that affect people, but also internal stigma. So what do people think of themselves? And I will say, and this is not overly fashionable, but often the stigma comes from within in many people. It's not just the outside world. And if you can't accept that you have an epilepsy and what that means and what it actually is, and how it affects you and the people around you, then I think you're a bit stuffed. It's kind of hard to talk about it with other people and to fit in, And as a generalisation, it's not the same for everybody. Different cultures, different backgrounds, different families, different friends, different employers. But we can't be hypocrites and blame the rest of the world for something if we're not willing to learn about the disease ourselves.
100%. And I love, I'm going to steal that internal stigma phrase, because that really resonates. I know I can relate to that too, something I still struggle with every day. And I'm just curious if you see that in your patients with like an internal stigma.
Absolutely, 100% of the time. It is there to some extent for I think everybody. It's how you manage it, and some people are better and have better insight into the workings of their mind, and that's where things like mindfulness, exercise, connecting with your body, those things help. Not only with epileptic seizures, but that actually applies way more to non-epileptic seizures domain as well. So it's true across the board. I would hazard, as you were saying, I mean, I totally echo you. Most of the stigma comes from inside, not from outside. Totally agree. And it is under-recognized.
Yeah, absolutely. And it just takes the work like you two. You two both. Oh, okay, the us three. I'll take some credit.
That's what we were saying. This PP, I think, this new dynamic at conferences, which I'm seeing, it's a really nice thing to be seeing happening. Having the actual consumers of what we are providing, the service, having them at conferences, it was never a thing. It's very recent. So it's a really nice thing to see.
Well, and as a patient, I appreciate that our perspective is wanted. And that it not only is it wanted, but that, like you're saying, like it's appreciated and connecting those dots. And that's something, I feel like that's a theme I've been hearing today from a lot of people, is that it's like we're kind of like arm in arm, like walking.
Feeling very positive that it will lead to better outcomes and good results. Yeah.
I mean, it's actually proven that it's not just a tick box, and we look good. It's not just good for image. It's actually good from a monetary perspective. It makes the work of researchers to be more focused. It enables them to work towards something that's likely to be more useful to the patient and the patient's family. So it's win-win. It just wasn't. It's cool now, guys. It's trendy. It's cool.
As epileptologists now.
What was that?
We're woke epileptologists now.
And it's as a team as well. Like you used a word, I can't remember what it was, but we are working together as equals. It's not just poor little patient.
Yeah.
It's our knowledge is very valuable in providing a service or a product that is effective and good for a market.
Yeah. Well, I love that you threw the monetary thing in there, because once you do that, then everyone pays attention.
Yes. So they should get in some good patients in for training for PPI if you need it, I think.
100%. Yeah, I feel like we'd be a great duo.
I know.
So we just walked in, and who do I see? The ultimate Nancy Volkers. Hi, Nancy. It's so good to see you.
Hi, Landis. It's great to see you, too.
So Nancy is the host of a podcast that I have been on, Sharp Waves by ILEE. It's pretty awesome, I have to say. I'm a little biased, especially my episode was pretty great. But just dropping that in there. But Nancy, so tell us, like, what your role is here, how things are going, what you're excited for.
My role is anything and everything. So whatever.
That's so true.
Whatever they need me to do, I'm doing right now. And then once the Congress starts, the sessions start, I'll be attending sessions, looking for story ideas, doing a couple of podcast interviews during the Congress, and just kind of mingling and meeting people and, meeting people face to face that I've seen on Zoom.
I know, that's what's so cool about right now. It was like literally like I turned around, I was like, it's Nancy, like someone I was so excited to meet in person.
It's very exciting to meet people that you've only ever spoken to on Zoom and never seen in person. And I mean, the program is amazing. I'm having a hard time deciding like which sessions to go to. So,
well, I'm a little biased. I think the brain tumors and epilepsy one is might be one you want to swing on by.
Well, I will do my best. I will do my best. And this is our biggest Congress in a long time. It's 4,200 registrants or something like that. So tons of people here from all over the world, and it's just super exciting.
Yeah, I saw that when it was like, there's over 4,000 people, and I was like, what? Like, that's insane. I mean, not that there will be 4,000 in one room when I'm talking, but like that's a lot of people to come out for this. It's amazing.
Well, maybe they will all be in the room when you're talking.
Of course.
Of course they will.
Well, thank you for everything you do. I really appreciate you, and I'm so excited we got to meet in person. This is just so cool. I'm like already on a serotonin high.
Excellent. Well, yeah, it was awesome to see you. I'm sure I'll see you again, and I'm very excited for the next however many days there are. I don't even know what day it is. I think it's Saturday, so that would be 4 more days.
Yeah, there we go. Okay, thanks. Hey, Ryan.
Hi. Nice to meet you.
Nice to meet you as well.
What brings you to IEC?
Yeah, it's great to be here. So I am a epilepsy researcher and a neurology resident physician at Barrow Neurological Institute in the U.S. But prior to that, I was based in rural South Africa doing epilepsy research for about 16 years. So I'm here to learn more about kind of the ongoing research and meet with colleagues like Mary, who you just met.
I interrupted that conversation. Excuse me, can I talk to you guys?
No, it's all good. It's all good. So just meeting up with colleagues, learning about some of the ongoing research and the new advances in epilepsy treatment.
Yeah. What has been like the thing so far? I mean, I know we're so early into the conference, but has there been something that really struck you?
Not yet. Like you said, I just actually arrived this morning.
Oh, wow.
So
welcome.
Just walked in. Yeah.
And you're like, great. And then someone put a mic in front of my face.
No, it's all good. It's all good. But no, just understanding. I mean, I think, my research is largely focused on population-based research. So rural South Africans in the first instance, people that live in rural areas that don't have access to basic epilepsy care.
Yeah.
And, there's been a lot of interest globally in reducing what we call the epilepsy treatment gap. So in the first instance, getting folks, that don't have any care, getting them diagnosed with epilepsy and then, getting them on basic anti-seizure medication. And so there's been a lot of interest in the last several years on this. And so learning what others have done. And I think that's one of the kind of the brilliant aspects of international conferences like this is bringing people together to learn from what others have done. So we don't need to reinvent the wheel.
Yeah.
And learning kind of the most effective ways of now engaging with policymakers and others that may have a little bit of sway on kind of the healthcare system and how we create a system that is more equitable for others. Epilepsy is a treatable condition, and it's about, getting folks the medication they need in the first instance, but then realizing it's not just about medication. There's other kind of factors with it, the psychological factors. And so in the first instance, in a setting like rural South Africa, it is about, basic anti-seizure medication, but then it's building out an entire healthcare system that can cater to the complex needs oftentimes of people with epilepsy.
Totally. I appreciate that so much because it's such a holistic thing.
Absolutely.
There's so much. Someone even said to me, I don't think we should call anxiety and depression comorbidities. We should just include it as a part of the diagnosis.
Absolutely. Yep.
Yeah. And so I really appreciate that. And just the idea that let's start with the basics, but then not exclude the rest of it.
That's right. No, you're absolutely right. And I think, that's one of the things, going back to your earlier question about what I'm so excited about here, I think oftentimes, and very importantly so, a lot of the focus is on intractable cases of epilepsy. So cases that, aren't controlled on multiple anti-seizure medications requiring maybe, epilepsy surgery or kind of more advanced needs. And that's, I think, very important, but there's also kind of the other end of the spectrum as well of people that just don't have access to primary medications. And so this conference, I think, what I'm excited about, having looked through the program and had a chance to, see some posters and talk to people is the fact that I think this caters for that entire spectrum, right? Because again, with my kind of inherent bias of coming from, rural South Africa, I think that a lot of the need, a lot of the burden, if you will, the kind of the epidemiological term of kind of where people with epilepsy live is in low resource settings. And so how do we kind of intervene to help those folks? And at the same time, how can we then, learn about those interventions there and apply it, in places like the US or other places, rural Appalachia, for example, or, I am based in Arizona now. So, a lot of the Native American populations have similar settings to what I see in rural South Africa. So how can we kind of apply what we learn here to places like there?
Wow, that's amazing. And thank you so much. Because this is something that has concerned me for it concerns a lot of people, but it's the reason I created my podcast is I was like, I want it to be free and accessible to anyone, anywhere.
Amazing.
And I know sometimes reading can be a little bit harder, especially after a seizure, and there's cognitive issues and everything like that.
Yeah.
But then I know, so I live in Chicago, and I'm so lucky that I have all those resources right there, right? Yeah. And that if I need an EEG, I might have to wait a few months, but it's not hard for me to go in and get one.
Sure.
And so I just really appreciate the work that's being done for the people who are not in places like that.
Yeah, absolutely. It's about figuring out, how to get resources to people that need it. It's funny you mentioned EEGs. I mean, when I first started, doing this research, I was actually doing a master's, and there was no EEG in the entire province that I worked in, a province of 8 million people. And so we actually brought in an EEG, and for the first 6 months, a year, I was doing EEGs, and for many of these people, and in the end there were about 450, a little bit less, 350 people with epilepsy in these communities that had never obviously had an EEG done before. And so to be able to kind of offer that was amazing, but also it opened my eyes to the fact that you're right. Growing up, in a place like Chicago, or a high resource setting, you have access to that. But how do we kind of get that access to people that maybe haven't had access before? Is something that I'm interested in.
Dude, your karma has got to be awesome because of the work you've done and continue to do.
Thank you.
Yeah. No, thank you. Truly.
I've been blessed and privileged to do what I enjoy and what I love, and that hopefully involves impacting people in a positive way. And I mean, I find this, just as personally and humanistically enjoyable as academically challenging and enjoyable. And so I've been really kind of blessed and lucky to be able to combine those passions.
Awesome.
So yeah.
Awesome, Ryan. Thank you so much. I really appreciate you.
Great chatting with you.
Yeah, you too. I am here with Wendy Steele, who is the founder and CEO of Young Adults with Epilepsy.
Yes.
Wendy, I'm so excited to meet you in person. Can you tell everyone what your organization is about?
One, I'm your number one fangirl. You probably have more than one. And isn't it amazing how we are meeting in Lisbon? Two Americans hanging. I mean, look how big this has all gotten. And I'm just so proud that I could be here and meet you. Young Adults is going on 3 years old. It focuses on young adults from 18 to 39. It's a really important audience to serve. And we're focusing on peer support for young adults, by young adults. So it's that lovely, authentic peer-to-peer contact. We have Monday, Tuesday, Wednesday, Thursday groups. We have Spanish. We're adding a women's. We're adding a men's. We have Discord, which I know you and I are still kind of figuring out what that is. But it's working and growing, and that's a very passionate community. If you join, you don't have to be on camera. You don't have to say anything. And come as you are. People call from, get this, hospital bed. One of our sweet team members did an Instagram live from her EMU.
That's fantastic.
It was great because she's all wired up. And all these moms and all these people are asking questions, obvious questions to ask, right?
Yeah.
And so she has some downtime, and so we decided to make it real.
You do have downtime in the EMU. That's so true.
So that was, so we're kind of all over it. But
well, you're crushing it.
Well,
I mean, it's amazing because there's so much power just in the power of connecting with someone else who understands your experience. Even if you don't go on camera, like you said, even if you don't talk, even just to see it. It's so amazing.
Yeah.
Well, I'm so excited you're here. I can't wait to hang out with you over the weekend.
I look forward to seeing you kicking off these panels with your humor.
Oh yeah, we'll see. I don't know. See if anyone else thinks it's funny.
Well, mutual admiration.
Yes, mutual love. Absolutely.
Thank you,
Thank you.